This is a short talk looking at one aspect of the use of echo in intensive care, and that's for measuring cardiac output. There's several different roles of echo, and the focus is different between cardiologists and intensivists in terms of the questions that they're trying to answer when they perform echo. This table lists some of the things which you can easily get from a standard transthoracic echo. So looking at the left and right heart, you can look at sort of chamber dimensions, wall thickness, wall movement, ejection fraction, regional wall motion abnormalities, which might suggest some regional ischemia. You can look particularly at the right heart for signs of pressure and volume overload that we've talked about previously. And then with an additional level of skill, you can comment on the structure and function of some of the valves. The aorta is a bit difficult really to visualise too much in the transthoracic echo. And then other things that we've talked about before, the measuring or the estimation of pulmonary artery systolic pressure from tricuspid regurgitation velocity, and also looking at some of the other pathologies, pericardial effusions and tamponade. Specifically when we use echo in the ICU, it's really a functional and dynamic assessment, and it's most commonly being used in the diagnosis of shock and looking to make some assessment of the response to treatment. So we want to know things like the cardiac output and the right and left sided cardiac function, and also an assessment of the preload, the filling state and volume responsiveness, and as part of that an estimation of right atrial pressure. There's two main methods for measuring cardiac output using echo. I talked briefly in one of the previous talks about Simpson's method, where the outline of the left ventricle is sort of traced, and then that space is divided up into a number of slices, and then each of those slices is considered to be a disc with a certain volume, and the volume of those discs is added up and estimated to be the volume of the left ventricle. And then that calculation can be done in diastole and in systole, and you can get a measure of the ejection fraction and the stroke volume, and from that you can work out the cardiac output. This method is not so easy and not so accurate, particularly with transthoracic echo. It's difficult to often get the picture that clearly shows you the endocardial border to enable you to do that tracing and the calculation and things. So a better method is using the left ventricular outflow tract Doppler. So if we just go through these calculations using this method, just think about the basics there. That cardiac output is the stroke volume times the heart rate, and what we're going to do initially is to calculate the stroke volume using some clever but simple maths. So if you think, and I've included the units in these calculations just to try and make it a bit clearer and show you how it all works. If you think about the flow coming out of the left ventricle in terms of volume per second, then that's equal to the velocity of the blood coming out of the left ventricle in meters per second times the cross-sectional area of the left ventricular outflow tract. And the stroke volume, which obviously is a volume, is equal to that flow in terms of volume per second times the duration of the ejection, which is in seconds. Another way to think this through is to think about the stroke volume is the cross-sectional area of the aorta times this concept called the stroke length. So basically this is one stroke volume which has been ejected into the aorta. It takes up that much length and that much area of the aorta. So the cross-sectional area, fairly easy, just pi r squared based on the radius, and this is measured here at the aortic root. So just at the base of the cusps of the aortic valve is where you measure that diameter and get the radius and work out the cross-sectional area. So this is in the parasternal long axis view on the transthoracic echo. The next thing we want to work out is the velocity of the blood travelling through that space. So this is using pulse wave Doppler. So this, with pulse wave Doppler, you can set what they call a gate, which is a little spot where you want to measure the velocity of blood at that point. So you can sort of see the little black square on the left picture, or the little sort of white sort of cross lines on the right hand side there. That's the gate, and then you position that in the left ventricular outflow tract, as close to where you've made that measurement of the radius as you can. We're in a different view now, so this is in the apical 5-chamber view, and the 5th chamber is the aorta. So once we've got the cursor where you want it, then you change to the pulse wave Doppler view, and that gives you a display like this. And you can see with time on the x-axis and velocity on the y-axis, with showing the blood flowing away from the cursor and going down into the aorta. You can see there the aortic velocity being measured with each ejection. The next thing we want to do is to integrate the area under that curve, and this gives us something called the velocity time integral, or VTI. So basically it's the area under that under this aortic velocity curve. So this tells velocity in meters per second times time in seconds, and that gives us a dimension of meters, which is this stroke length that we were talking about before. So putting it all together now, the cardiac output, which is volume per time, litres per minute usually. Obviously meters cubed is not litres, so you just need to convert that. But this is equal to the cross-sectional area in metres squared, which we calculated from the radius at the aortic root on the parasternal axis view, and then that's multiplied by the velocity time integral, the VTI, in metres, calculated from that apical 5-chamber view using the pulse wave Doppler, and then that's multiplied by the heart rate in terms of beats per minute.